Okay, so as we get started, feel free to enter your hospital name and your favorite local place to visit or your favorite local event to attend in the summer, and we will go ahead and get started. So this is our agenda for the day. We're going to do a very brief data update, and then we will have CDPHE present on the syphilis update in Colorado and the new public health order. And then we will hear from Carly Swinson on some actionable steps to decrease stigma and bias during the birth admission. And then, of course, we'll have Moms Plus provide a program update. So after the last Learning Collaborative call, we sent out a survey to each of you to learn more about what barriers you are facing when it comes to data collection and submission. And these were some of the quotes and findings that we found in that survey. And of course, thank you to everyone who completed that survey. We got an overwhelming response compared to what we were thinking we might get. So thank you for taking the time to do that. Please know that we are taking your feedback seriously. This is a QI initiative, so we do take QI seriously. And so we will be taking these quotes and the findings and incorporating them into the next few months of data collection and submission. Some of these won't be immediate changes, but please know that they are on the way. So thank you for that feedback. So now we are going to hear from CDPHE and about syphilis.
Good morning, everyone. My name is Adriana Hervey. I'm with the Office of STI, HIV, and Viral Hepatitis here at CDPHE, and I have a few of my colleagues on the line. Dr. Jackie Denning will also be joining me today in the presentation. I know we have about 15 minutes. We have a lot of data to share, but we will be joining you again in a town hall a few months from now. So if we don't get to all of your questions, feel free to reach out to us, and we'll leave our information in the chat. Sarah, are you going to be running our slides? Okay, if you want to go ahead and get those up and we can get started. Very happy to be here today. So we're going to take a quick look at syphilis in Colorado. We'll talk a little bit about what is syphilis, what has brought us to the point that we needed to issue a public health order. We'll talk a little bit about treatment. We'll show you some high-level data, and then we'll answer any questions that you have related to syphilis. So syphilis cases not only in Colorado are on the rise, but nationally. For folks who don't know, syphilis is a bacterial infection that can spread through a sore, through a vaginal, anal, or oral lesion. It spreads from a pregnant person who is untreated to their unborn child. This is called congenital syphilis. Syphilis is 100% curable, but there are complications and consequences if left untreated that can be serious and then sometimes fatal. Someone who's pregnant with untreated syphilis passes it on to their unborn child and can result in developmental delays, death, or deformity of the infant. Next slide, please. And so syphilis comes in stages: primary, secondary, latent, and tertiary syphilis. Most folks are familiar with primary syphilis. It starts out with a lesion in an area where you're having sex. That symptom can appear as early as 10 days up to 90 days. It requires a blood test to determine if you have syphilis or not, where most folks may be asymptomatic, especially in pregnancy. So the only way to tell if someone has syphilis, if they're not exhibiting any symptoms, would be a blood test. Next slide, please. The treatments for syphilis are highly effective and they do work. So anyone who thinks they've been exposed to syphilis, they may be exhibiting symptoms that resemble syphilis. We recommend that you reach out to your provider, get the screening test, get appropriately staged, and early with antibiotics is the most efficient way to prevent congenital syphilis cases. Next slide, please. And so people are like, how did we get to congenital syphilis? Why is syphilis on the rise, not only nationally, but in Colorado? So here are some of the factors when we take a look at our data. STI clinics are usually under-resourced. In the Metro Denver area, there's really only one official STI clinic, and that's Denver Public Health or Denver Sexual Health Clinic. They've renamed their clinic. Not all health providers are ultimately trained to handle syphilis. So most folks may see it in the residency, but they haven't really seen it in life practice. The changes in sexual practices amongst individuals can also be contributing to that increase. Barriers for folks to access care. They may be experiencing substance misuse, economic vulnerability, and homelessness. And then the stigma associated with screening positive for any STI. And then particularly in congenital syphilis, what we're seeing is folks are lacking in prenatal care or they're not engaging in prenatal care at all. A lot of folks are also receiving most of their care through the emergency room or urgent cares. And then we've also seen a spike in reinfection or late infection diagnosis in pregnancy. Next slide, please. And so before we share data, we always like to share our equity acknowledgement, and I'll just read it. The Colorado Department of Public Health and Environment acknowledges that generations' long-term economic and environmental inequities result in adverse health outcomes. These inequities affect communities differently and have a greater influence on health outcomes. Other outcomes than either the individual choices, their ability to access healthcare. Reducing health disparities through policy and organizational systems can help improve opportunities for all Coloradans. CDPHE aspires to present data humbly, recognizing statistics and numbers overall do not tell the complete story. The goal is to work collaboratively with individuals, providers, and communities to learn and share their stories and build a collective understanding. Next slide, please. And so as we take a look at the data, this is just an overview of a heat map of what syphilis looked like, all stages by rate in 2019 versus where we are in 2023. I do want to say our 2023 data is preliminary. We're finalizing the data to get ready to send that on to CDC. We do share the numbers in real time, but we want you to know that the data is subject to change. So what we saw is that syphilis was really happening in our southern region. And then you can see as in 2023, it's kind of starting to pop up in all of the counties. Next slide, please. So this is a look at syphilis all stages on the left versus our congenital cases on the right. So it's a 20-year look at cases. So you can see in 2023, we had very few cases. And then as syphilis started to increase, we also saw an increase in women. And then we also saw an increase in our congenital cases. And so we're currently at 51 cases of congenital syphilis for 2023. And again, that data is preliminary. Next slide, please. So this is just a look at the rates amongst men and women. And what we know historically about syphilis is that syphilis has been mostly found in men, especially men who identify as men who have sex with men. But what we're seeing in the data as you look at 2021, 22, and 23, we're starting to see in some of our counties that women are outpacing men on the increase in syphilis. And so that's why we're seeing that increase in congenital syphilis. And again, the data for 2023 is preliminary and subject to change. Next slide, please. So from 2019 to 2024, we've had 20 cases of stillbirths or infants who died shortly after being born amongst our congenital cases in Colorado. These deaths are completely preventable through screening and appropriate and adequate treatment in that pregnant person. Next slide, please. And so to address the rise in syphilis cases, Colorado needs to do close the loop on some of our screening gaps. So we wanted to increase screening in emergency departments and urgent care. We also want providers to include syphilis screening when they're screening for other STIs, gonorrhea, chlamydia, any other STI you're screening for, herpes, hepatitis. And then we also want referral networks established between social service providers and STI providers, OB providers, anyone who's seen folks who can get pregnant. And then we want to improve access to prenatal care. And then we've worked with our other agencies like the Division of Insurance, HICPUF, and others to work on other challenges and vulnerabilities such as homelessness, substance use, economic vulnerability, folks who are involved with the justice system, and trainings around stigma. Next slide, please. I'm going to turn the slide over to Dr. Denning, and she'll talk a little bit about the public health order.
Hi, everybody. Due to these changes that we've seen in the state of Colorado as well, this is in the context of nationally increasing numbers and changes in recommendations by organizations such as ACOG for screening additional times in pregnancy. We have a public health order in the state of Colorado now. This took effect back in April. And we are asking prenatal care providers to offer testing in the first trimester, which has been standard. At that first prenatal visit, that's been pretty standard for quite a while. We are asking for additional testing in the third trimester and at delivery. This is due to 80% of females in that 15 to 44-year-old age group in Colorado now live in an area with high enough syphilis rates that CDC recommends additional testing. We are also asking providers in emergency, urgent, correctional care, if you're a medical provider and you see a patient and they are pregnant, if you do not have documentation or the patient can't tell you that they've had syphilis testing, we are asking that you offer syphilis testing 3 times during pregnancy, because we are seeing that these congenital cases are happening more in folks who are not accessing regular prenatal care, but some of them had accessed care through emergency, urgent care, or other settings where you might not think of prenatal testing quite so frequently. And the public health order does say that providers need to offer testing, not that it has to happen. Happy to answer any questions about that. Next slide, please. So this is the direct text from that public health order. You can see there, it kind of talks about first trimester, third trimester. If there's a fetal death, we ask for that as well, if it's after 20 weeks, or if a pregnant person presents to a medical provider outside of those settings. Next slide, please. So we have multiple things we're asking for help with, right? So our call to action for the population level is, if you are pregnant, please engage in prenatal care. We are recommending STI screening for everyone in Colorado, including syphilis testing for anyone who is sexually active 15 to 44 years of age. If you do have positive testing, we are asking you to complete that treatment and follow up with your provider as well. We want to make sure that we are encouraging everyone to talk to their partners, protect your partner, take proper precautions if you're being treated so that you're not having reinfection risks. Next slide, please. And then we have some specific resources we wanted to point healthcare providers to. There's some resources on taking a sexual history. This can be part of the paperwork that folks fill out before they come back to the room. That is available in English and Spanish. We do want to offer syphilis screening to all sexually active people in the state of Colorado. We have that 3 times in pregnancy that we just talked about. We do want to confirm syphilis test results, history, and treatment, and we have folks who can assist you with that in our case ascertainment area. We do want to treat infected patients immediately, and there are some special cases where you may have a point of care test, or a pregnant person or a person with transportation difficulties you think may not be able to come back for follow-up, where you might treat empirically if you have a very high suspicion. We also want to make sure that we're reporting positive syphilis results to CDPHE within 1 working day. Email is great for non-pregnant folks. For pregnant folks, we would love a phone call because we set up close follow-up with those folks. And if it's possible for your facility to shift over to opt out rather than opt in or risk-based testing, because we currently, our numbers in Colorado are such that risk-based screening is not sufficient. Again, anyone who is sexually active in the state of Colorado is currently at increased risk for syphilis. So please keep that in mind. And next slide, please. And I think I'm going to turn it back over to Adriana here. Thank you so much.
Sure. Thank you for that, Dr. Denning. And so I just wanted you all to see some of the CDPHE partner services support. So this is a nice picture of the folks who do our contact tracing. So they're known as disease investigative specialists. They provide partner services, which is clinical evaluation, counseling, diagnostic testing, partner notification services. And it's just on that continuum to get folks in timely tested, treated, and to eliminate the spread of syphilis infection. So you will get the slide deck, and it has everyone's contact information on that slide if you need to reach out at us in any way. Next slide, please. And so short-term case management for clients for timely syphilis treatment, these are some of the things that our DIS team can offer. They can offer transportation to appointments. We do offer incentives for folks to complete treatment. So those are like King Soopers, gas cards, and things like that. We can assist in scheduling appointments for clients and their sex partners to go in for screening and treatment at the local public health departments. For our pregnant patients who are being diagnosed as latent, they need 3 weeks of shots, and so we do provide temporary cell phones so that we have a level of contact to the client to ensure that they're making their appointments. If we need to contact them for any reason for treatment or lab results, then we will utilize that incentive. And then we do offer temporary short-term shelter for folks who are pregnant while they're receiving their treatment. We have a field delivery program for folks who are missing their follow-up appointments with providers for treatment. They can fill out this form in the hyperlink. It'll take someone about 24 hours to give you a call back and schedule that follow-up appointment, where they will go into the home and treat the patient and their partner for syphilis. We have a bicillin access program where we know there's a nationwide bicillin shortage for providers who don't have access to bicillin or they don't have it on hand at their facility. They can fill out this form. We will drop ship bicillin to your provider at no cost. And then we also have a rapid test point of testing, care testing that happens either with our DIS or we can train folks to actually have the test at their facility and run the rapid test in office. Next slide, please. And we can go on and skip this slide. I know we're running out of time. Next slide, please. And so that's basically the services that we offer and how we are collaborating with the other agencies in the state and providers. At this time, I'll stop and see if there's time for questions.
Yeah, while you guys are thinking of your questions, I'll go ahead and thank Dr. Denning and Adriana and your other team members who are still on the call with us today too. Team, they are going to be back with us at our in-person forum in August to share an update and more information. And so look forward to that, but feel free to use the chat or come off mute here for just a moment or two. I think I wanted to quickly make the connection to why are we with our perinatal substance use quality improvement program really highlighting syphilis as sort of a key topic for our population. And one of the things that Adriana pointed out is that patients experiencing substance use are one of those higher risk populations. But as Dr. Denning pointed out, all of our patients are now considered a high risk population. And so I don't want these patients birthing pregnant and postpartum individuals who are experiencing substance use to be an overlooked population. Sometimes the clinical care that's involved with managing substance use can overshadow the other clinical care that might need to happen for those patients. And syphilis is one of those pieces that we don't want to be overlooked with these patients. We'll keep the line open for about 30, 60 seconds here. Please come off mute if you guys have a question, use the chat. And if there's no questions, we'll move on.
So thank you for your time today. And when we meet again in August, we'll do a deeper dive into the actual cases and should share some more of the missed opportunities that we can share from our 2023 and 2024 data.
Awesome. Thank you, CDPHE team. We always appreciate your partnership. I'll turn it back over to Sarah.
Great, thank you. I don't see any questions in the chat. So I will actually be passing it to Dr. Carly Swinson to talk about some actual steps for stigma and bias.
Okay. Hello, everybody. Let's see. Let me get my screen shared correctly. Okay, so I think that that's working. So today we're going to be talking about stigma and bias in the context of perinatal substance use in labor and delivery units. And I think the nice thing about the people on this call is that I don't necessarily have to give the why we are here and why we're doing what we're doing, because you're all here, which means you're all invested in improving care for pregnant and postpartum patients who do struggle with substance use. And I think in this situation, a lot of what we are told from units and what we've all experienced is that people want to do the best they can, but have no idea what that means. They don't know when a patient walks into the room and they suspect that they're using substances, what they're actually supposed to do and how it benefits this patient. So today we're going to go over 10 actionable steps, things that you can do as an individual, as a person on your unit, if you want to be a leader on your for your hospital or in your system to address perinatal substance use. And hopefully you'll walk out of this feeling a little bit more like you've got some tools in your back pocket and like you know what to do, and when you don't know what to do, you know who you can ask. So we're gonna go kind of linearly. First, one of the things we have to do is we have to know that the situation exists. We have to understand the prevalence of perinatal substance use, the outcomes of perinatal substance use, and how much perinatal substance use and accidental overdose do contribute to maternal mortality and morbidity in our state. Some things that as an individual we can do to start understanding these things is to read up on some of the literature showing that addiction is a chronic but treatable medical condition. I think that this is kind of the basis of providing empathetic care here, is understanding that substance use is not a moral failing, but that something has happened in this patient's life that set them on a trajectory that no one's enjoying. No one wants to be in this situation. So understanding that we should be treating this similar to how we would be treating gestational diabetes or chronic anxiety or anything else that we give the respect of being a medical condition, we should do that with substance use disorders as well. And also something we can start doing is recognizing on our unit how often people are either using substances or being suspected of using substances, just to get kind of your initial checkpoint on what's going on my unit. And how often are we testing? What are we thinking about? How often are these conversations coming up? Some units talk about it all the time. Some units, if one patient comes in with substance use, it's a big deal. So we need to know where we are at. And we also need to ask questions to the people on our units when we want to start getting involved. To be like, hey, how often are we seeing this? What are we thinking? What is our unit's next steps for this? And another thing that we can do, let me move my little Zoom box, is so tiny. There we go. Second, what we need to do is to know or change our unit's policies. Obviously, we're all held to the policies of our unit, and if we don't know what those are, we can't be providing the best care. There's some different policies that we recommend everybody gets put in place. The first one is toxicology testing. The guidelines are changing across Colorado. If you want to reach out to us at CPCQC, we've got the updated Support Colorado guidelines for tox testing that really emphasizes informed consent and partnering with the patient and understanding what the results of a tox test are going to give you as a healthcare provider, and also how it's going to affect that parent. We need to get those in place. And also CPS reporting policies. Recently, the verbiage in the law was updated. It used to say that a mandatory report was a substance exposed newborn, and now the verbiage is that the infant has to be exposed to and affected by substances. And this, some people are finding this a little vague. So if you need some information or some examples about what this means, please reach out to us. But we do need to do some education on our units that not every positive tox screen requires CPS reporting, and that it's actually on a individualized basis. And we also need to know if you're participating in CPCQC's substance use initiatives. I'm assuming most people on this call are because you're here, but sometimes we get some stragglers, so I needed to still include it here. And please reach out if you're interested in getting more involved. Okay, now we're going to talk about things we can do as an individual. I think the first and the easiest option is to start recognizing and changing your own language. So in the orange box, we've got some words that are not necessarily bad words. They're common words that we hear all the time, but they carry really negative connotations that can be harmful to some patients. And it is such a simple switch when we are interacting with patients and with our coworkers to switch some of this verbiage into the less harmful alternative. So one that's always surprising, I think, is that people will refer to a clean drug screen as a good thing, which is fantastic that they had a negative drug screen. However, you're saying that if it had been positive, you're implying that they're a dirty person. So these small switches, talking about not calling a patient an addict, but referring to them as someone who does have a substance use disorder or is struggling with a substance use disorder or who is misusing substances, is such a less harmful connotation when we're talking about our patients. And that helps with this transition from immoral failing into medical management. The fourth, and this is actually my favorite of all of the options, it's to implement small changes in how you react to your colleagues. So there's a million ways to do this. Here's a bunch of examples. If you say you're at the nurse's station and one of your coworkers is complaining because they have another patient with substance use disorder and they're not very excited about it, the power of a brief, empathetic response is what helps change the culture of how we talk about these patients on the unit. So some really effective responses that I've seen are something like, wow, that's a really unfortunate situation. I hope she can get the support she deserves. Or I'm so sorry she was being rude to you. I bet she's really scared right now. Or I learned that over 50% of people who use substances in pregnancy have a history of physical or sexual trauma. We should probably make sure that she's okay at home if we haven't already. I saw a flyer in that drawer over there about how patients who have a history of meth use, maybe the resources on that flyer would be helpful to her. Or I heard she was in recovery. What an awesome accomplishment. That must be really hard. And last would be, I heard she recently relapsed. I hope her home situation is okay. Maybe we should talk to her about her support system. And these, I've used them myself on the floor, and I think that they're very helpful. It just changes the connotation of the conversation from a complaining about a patient or gossiping about a patient type of tone to demonstrating empathy, and that even if this is not your patient, by responding empathetically, you're saying, I care about this patient and I hope she's doing well. And that helps teach your coworkers that it's also not okay to be condescending or rude or gossiping about these patients who are really struggling. And you will mess up, and that's okay. All we ask is that you try again next time, and that when we're doing this over and over, you keep trying to implement these different responses that you can have. Okay. Fifth is to be a leader on your unit for patients with substance use. We all have been on a unit where we get something, we're like, I don't know what to do in this situation, and I don't know who to ask. And if you are someone who does know the answers on your unit, being the person that people know to go to is a huge change for all of the other staff. Some things that you can do that might have them view you as a leader on the unit would be knowing where your unit's resource list is stored and actually providing it to the patients. Knowing if your unit has peer recovery services, at the CU system, you guys have built in peer recovery services, but if you're not, please talk to us if you want to get involved with Hard Beauty, and know that you can refer patients out to pregnancy and postpartum friendly substance use recovery services that exist across the state of Colorado, both in person and virtually. Know where the naloxone is stored. Is it in the crash cart? Can you send your patients home with it? Do we know what to do in the event of an accidental overdose if it were to happen on the unit, whether it's a patient or a patient's family member? Get to know your social work team and make sure that they're aware of the unit's resources and you get comfortable with talking to them. I know just recently we were in a conversation where some of the L&D nurses were referring to social work as the bad guy. They were like, we don't want to talk about all of these things, so we let social work be the bad guy and talk about substance use. And we're like, well, if you portray social work as the bad guy and patients are already afraid of social work because of the involvement with CPS and the fear that they can get their baby taken away, no one's going to be either empathetically providing or being receptive to the resources that we're trying to give them. Initiate a warm handoff to the NICU or nursery or pediatrician, wherever this baby's going, with a plan of safe care. And this doesn't have to be intensive, but as little as a simple phone call down to the NICU to say, hey, this is what's going on. This is how we're dealing with it. This is what's coming over to you. Please contact me so we can talk about the plan of safe care for this baby, this mom, and this family. And also demonstrate by example how to have empathy with difficult patients, quote unquote difficult. Teach the new grads and don't be afraid of the way it's always been. I know that sometimes we don't want to take the quote unquote challenging patient, but when we do, it's showing to all the other nurses that we don't have a reason to fear this patient population, that it's very similar to many of the other patients that we deal with. And it teaches them that this is not an intimidating population, that we have the skills to work with them. And work with your OB and anesthesia providers to make a comprehensive treatment approach for patients with substance use or who are on medication for opioid use disorder. Sometimes you might have to bug L&D anesthesia. You might have to bug your OB attendings, whatever it is, initiating those conversations and being like, hey, I want us to have a protocol on our books about what we do when a patient comes in on MOUD, and I need you to work on that with me. Let's set a meeting time. Sometimes they just need someone else to initiate the conversation. Okay, so this was all behind the scenes. This was not to the patient, but more so what you were doing. Now we're talking about your interaction with the patient. And the first and I think most important is how you talk to the patient about substance use. And the primary example is how you discuss a screen, whether it's positive or negative, and how the words that you use set the stage for all of the future interactions with this patient. Some of the things that we'll ask you to do when you're talking about substance use, this is similar to how we would do it with screening for domestic violence or being safe at home. Please don't discuss it in front of a visitor or a partner, even in the screening. And I'm saying, please don't ask the partner to step outside the door and stand right there for 30 seconds. But I'm saying, tell them to go get the mom a snack, send them down to the cafeteria, send them on a walk. I don't really care where you send them, but send them away for long enough of a time that whether this patient says, no, I don't use any substances, or they say, actually, I've been having a really hard time with my anxiety medication. I think I've been taking it too much. Or like, I had a really difficult time stopping drinking in pregnancy, to be totally honest, and I'm not talking to my partner about it. Please make that private scenario. We're going to ask you to sit down at eye level, uncross your legs, uncross your arms, turn the computer screen away, even though we have to click through the click boxes. Take a deep breath, soften your voice, and be honest with this patient. Please say that substance use is really prevalent and that we have resources that we can provide, and that we need to ask them these vulnerable questions, because if they need help, we have help to give them. Don't do it just to check the box. Please be genuine with these patients. And I get very flustered about when people say, you're not using drugs right, or no alcohol right. because no one's going to respond honestly if you ask that, and we've lost the opportunity to intervene. And then practice what to do if they say yes. If a patient says, yes, I've been using off-label pain medication, yes, I've actually been struggling with alcohol, whatever it is that they say, practice internally what you're going to do when they inevitably say yes. We have scripting. If you want it, please reach out to us. But this can be as simple as sitting down with one of your colleagues during a slow moment on the shift and be like, can we just role play this really quickly? Because I want to know what to do when it happens. And please acknowledge and appreciate their honesty if they say yes. Say something to the effect of, thank you so much for sharing that with me. That must be really hard. You know, postpartum is probably going to get a lot harder. So let's work together to get you all of the resources that you need. Okay. Educate your patient on harm reduction. The world would be an incredible place if patients could just say, yes, I've been using, and we can say, please stop doing that. And they say, okay, I will stop doing that. But that's really not the reality that we live in. And so teaching about harm reduction, both for themselves and their baby, can help save lives. The first one's naloxone. It is safe for everyone. It only works if opioids are in the system, and it really should be given out to people who are using any substances, because so many substances can be cut with fentanyl that we should have naloxone on hand. We should be teaching about avoiding co-sleeping, especially while under the influence of alcohol or other substances. People just might not be thinking about it. Talking about how to ensure a sober caregiver. If they know that they're going to use at XYZ time, similar to how a lot of parents want to go to the bar after they've had their baby and they want to have some margaritas and have a good time. It's not different with other substances. So we need to talk to all of these families about how they can make sure that during those times, baby's in a safe environment. Have a conversation about setting limits on when to use substances, where to use substances, who to use substances with. And even just initiating this conversation might help the patient identify some of their patterns of behavior that they might not like. Maybe they realize they're only using when they're around this one friend or a partner that they don't really want to be with, or with coworkers at this job that they don't really like. And so pointing that out can help them understand their own patterns of behavior and how they can handle those. Talking about decreasing use, even if stopping isn't feasible, is a great harm reduction technique. Providing information about support groups, in addition to the typical Alcoholics Anonymous, Narcotics Anonymous, there's also ones that are specific for pregnancy and parenting individuals, like the hard beating ones that I mentioned earlier. And very importantly, sitting down with the patient and helping them make a list, write it down, put it on their phone, I don't care where you put it, of who they can call if they need help. If they need help for themselves, if they need help from baby, whatever it might be. This could be their sister, their neighbor. This could be 911, depending on the scenario. But I want these patients to walk out of the birth hospitalization with a list. So when or if something goes wrong, they know exactly who to call to intervene quickly in that scenario. And also talk about the risk of overdose postpartum and how tolerance can change during pregnancy. Many of the patients that you're going to be interacting with were using more using more before pregnancy. And then once they find out they're pregnant, they're able to decrease use, even if not stopping use. But a lot of the time postpartum, people think, okay, well, I'm not pregnant anymore, which means I can go back to using the level that I was using. But if they have been in recovery for a couple months, or if they've been reducing the amount that they've been consuming for multiple months, if they jump back up to their initial use levels, that is what's going to cause an overdose, because their tolerance level has gone down quite a bit. So having that conversation can improve their own understanding of the risks without just being punitive and saying, you know, this is really bad, you shouldn't do it. But actually helping them understand their own body and their own use can be really helpful. Okay, that was with your patient. Now we're talking about your patient to other people. I want you to advocate for this patient to have the best experience that they can, because if they have a good experience, they're more likely to enter hospital-based recovery services. And if they have a bad experience, why are they ever going to go back to a provider again? Or to their 6-week postpartum appointment, or to their kids' checkups, whatever it might be. We want them to have a good experience. And we can address if her pain is being adequately managed. If it's not, advocate for her. She's in labor, it's objectively painful. Talk to anesthesia, talk to the providers and say, I think she's still in pain, and I think that we should be managing pain appropriately. Can you introduce her to social work? And I mean like a physical introduction, beyond just saying, hey, I'm calling social work, which might come off as punitive, even if you don't mean it to be punitive, but saying, you know, so many of our families here see social work only because they have so many resources and postpartum is really hard. Is it okay if I introduce you to social work? And when you do, physically going in the room and saying, okay, like this is Karen, she's with social work, I trust her, she knows your situation, she's going to help talk to you about some options that you have. So that way the patient knows if the patient trusts you, if you're a trusted person and you trust social work, that helps build the relationship between the patient and social work, instead of social work coming and knocking on the door and saying, hi, social work, and the patient having no clue that they were being sent over. Did you give a consent conversation for toxicology testing? And I say a consent conversation because sometimes we say, did you get consent? Which is technically true, but it makes it look like consent is another box you just have to check, when really we should be initiating a conversation about why we're toxicology testing, especially if they already said that they're using, why a urine screen is going to help the doctors in their medical care, and also being honest about what's going to happen if the test is positive. They want to know what's going to happen, especially if these events are inevitable. Giving them a heads up makes you more of a trusted person. Again, can you educate her about postpartum overdose and changes in tolerance? I'm saying this twice because that's what affects mortality, and accidental overdose is the second leading cause of death during pregnancy and postpartum. So again, tolerance. Did you teach her how to use the naloxone? It's great if you distribute it, but if you distribute it and no one knows how to use it, it's completely useless. So please teach her the few steps of how to use the naloxone. Can you introduce her to the next shift nurse? I know that shift change is busy and it sucks and everybody wants to leave, but for 30 seconds, if you can walk in and do the same thing you did with social work and say, hey, I have to head home. My shift is ending. This is Lacey. She's going to take care of you tonight. Lacey's fantastic. She knows what's going on with you, and I'm going to see you in the morning. Or if you don't think you'll see this patient again, if she's going to be discharged, say something to the effect of, I hope things go really well. Like, please know that you're safe here if you need to come back. So that patient can trust who's going to be taking care of her. And if she's about to be discharged again, does she know who to call if she wants or needs help? And this is individualized for every patient. Please sit down with them and help them make this list. Okay. 9th would be involve your patient in the care for the newborn. If baby's in NICU, if baby's in nursery, whatever it might be. Sometimes parents need a little extra help teaching or supervising the patient in bathing the infant, feeding the infant, changing the diapers, consoling the baby when possible. If this baby is being discharged with mom, we better make sure that mom is confident in what she's doing, and sometimes they need a little extra help. So please be there, even if you think it's something that's obvious. Call lactation if you think that she needs help with breastfeeding. Teach her how to change a diaper if she's never changed a diaper. Just have some of the empathy for this mom who might not know what she's doing, which many moms don't know what they're doing right off the bat. And when the parent is unavailable, please utilize volunteer cuddler programs. Most of you have them. I'm a cuddler at Children's. It's the best thing on the planet. We are literally there to hold unconsolable babies. So if this baby is in withdrawal, if they're doing eat, sleep, console, and they just need to be held and mom can't be there, it is as easy as a call down to your volunteer office and they'll send somebody up. And last, we're going to set the patient up for success in the future. So whether this was a unintentional pregnancy, an unwanted pregnancy, or a very, very wanted pregnancy, as this mom's leaving L&D, we need to set her up so that this experience doesn't happen in the future if it doesn't have to. So having conversations about birth control, whether this is you talking to the OB, whether this is you setting up her 6-week appointment, have the conversation. If the patient does not want to get pregnant again, that should be in her control. So we should give her the tools to avoid an unintended pregnancy. This is conveniently with the syphilis conversation. So we should be doing STD panels. Extra important if patients are participating in sex work to obtain substances, but this is across the board for everybody. You have her captured at L&D, STD panels, intervention for any STDs that come up positive, and education moving forward is incredibly important. And then offer to involve the family. Some patients don't want their family knowing about substance use, and that's fine. That's HIPAA, do not break that. But if the family is interested and aware of the substance use that's going on, offer to involve them. Mom, dad, aunt, uncle, sister, brother, grandma, neighbor, whoever it is, if this family is going home and they are privileged enough to have a village that's going to help take care of this baby, teach them the same things. Talk about the changing of the diapers and the baths and the sleep and the safe sleep, especially if under the influence of substances, whatever it might be. Invite those people into the conversation if the patient's comfortable with it, and set them up for the best and safest care that they can have when they go home. And that is the 10 steps I have for you. I'll end it on the reaffirmation that if this patient has a positive experience in L&D with the healthcare providers that she sees during the delivery hospitalization, that's incredibly supportive of them later initiating recovery services or just having more interactions with the healthcare system. Their postpartum appointment, baby's newborn appointment, pediatric appointments, whatever it might be. But if they have a negative experience at L&D, why would they come back? If people were rude or dismissive, why would they bring their baby back to the hospital? And I do have a bit of an optimism bias, but there's so much that we can do, just like there is for patients who have postpartum anxiety or who have hypertension. We have so many tools in our toolkit that we need to implement, but to do that, we just need some change leaders to start actually doing it. So if you hopefully feel like there's a few more tools in your toolkit now, but also know that you have resources to reach out to if you start implementing these things and it feels a little iffy. Talk to your unit educator, talk to us at CPCUC, shoot us an email. We are all very responsive. And we want you to know that you have support in changing the culture on these units. If anybody has questions, feel free to put them in the chat. But if not, I will kick it back to Sarah. Pia wants to be a cuddler. It's the best thing ever. I'm biased. I'm obsessed with it. But because you're not in charge of the medical care, because they're in the NICU, so you can just put in some noise canceling headphones and just rock the baby and listen to a podcast, and it's the best thing ever.
Awesome. Thank you, Carly. Yeah, if you guys have any questions in the last few minutes of today's webinar, feel free to put those in the chat, or if you have questions afterwards or would like to schedule a stigma and bias training with Carly, please reach out to me and I can connect you with her and we can get that scheduled. I will now pass it over to Rachel from Moms Plus.
Hey guys, can you hear me? Sorry, I just got back from staffing. Yeah, our Moms Plus cohort update, we just continue to grow and build on this wonderful foundation that Colorado AIM SUD program has established with many sites. So we'd actually like to welcome, welcome Platte Valley Medical Center and St. Mary's Regional Hospital, as they have been Colorado AIM SUD sites in the past and are going to be re-engaging and joining our Moms Plus cohort for kind of 2.0 version. So we're really excited. We actually now have all of the Intermountain Peaks region Colorado birthing hospitals enrolled. And so that's a pretty big deal. And I would challenge other systems, if you're on, to maybe think about how to get some of your other sister sites involved, but very thrilled for that. And then another one in the southwest corner of the state is Southwest Health System. And so we welcome them as well. I don't know if any of them are on the call today and want to come put their video on so we can see new faces, but I think that this will really be key as we expand into outside of the Front Range and into more rural sites. Hey, Nikki, are you from South? Oh, awesome. Yeah, so great to have you here. Nikki, do you want to tell us just a tiny bit about Southwest?
Sure, I would love to. We are in, like our name says, Southwest Colorado, actually in Cortez, Colorado. We had 140 births last month, so we're definitely lower volume, but very excited at the opportunity to get to collaborate with all of you guys and improve the care for our patients, our community, and our whole trajectory for the future. So thank you.
Awesome. Well, Nikki, welcome to this wonderful cohort of humans. And you join, I think we're almost up to 20 hospitals now that are enrolled and participating. So yeah, we just continue to work with both round 1 and round 2 sites. Had a lot of great quarterly one-on-one meetings and post-site visit debriefs this month. So yeah, more to come soon. And we'll be giving the talk next month on harm reduction in naloxone, of course. So great to see y'all.
Thanks, Rachel. This slide we've showed quite a few times over the last few learning calls, but really want to reiterate the fact that SUD, Moms Plus, and Chosen Quick are really aligning messaging and effort, and we're really trying to overlap some of our events as well, as you will see with our fall forum. But I want to put the plug in again for any hospitals that may be working in 1 or 2 of these programs already that would like to expand over into the other programs on the screen. We'd really like to see how we can make this care for this dyad even more robust across the state. Most likely, if you're on this call, you're participating in SUD, but if you're not yet participating in Chosen, please reach out. We would love to work with your NICU teams, mother baby, to see how we can provide that continuum of care for this dyad. Or if you're doing it really well and you're already doing all of these things and want to pilot, we'd love to hear from you as well, so we can help other hospital teams learn from you. Ooh. This was our flyer for our fall forum. Again, it's going to be hosted by CPCQC, Moms Plus, and Chosen. It will be held August 23rd at the UC Anschutz campus. Registration is going to launch early next week, so be on the lookout for that, and be sure to invite members of your team to join us. If there are any questions, feel free to put those into the chat or come off mute. We're happy to help you and answer any outstanding questions you may have from the content or just the initiative in general. And as a reminder, Rachel just mentioned, our July Learning Collaborative call will focus on harm reduction. So we'll dive deeper into some of what Carly talked about today, talk more about naloxone and Narcan, as well as some other topics related to harm reduction. And we will see you in July. We'll stay on a couple of minutes longer, but feel free to hop off if you don't have any questions.